Here are some of my cases from our lab. So again, we see that really thickened LV wall and that thickened posterior wall with the dilated left atrium. So this was a 71-year-old African American man who'd been admitted with heart failure. He kind of an extensive cardiac history, coronary artery disease, prior stenting, diabetes, hypertension, dyslipidemia, former smoker. I think on prior admissions it had been attributed to his history of hypertension. And we see here the walls are quite thickened with the posterior wall of 19. And again, very typical findings on the rest of our views. So we've kind of got a very restrictive filling. And this patient was actually in sinus rhythm. But you can barely make out the A wave, if you can see it on that mitral inflow. It's just all E wave and a really diminutive A wave. I don't even know if it was measurable. Definitely less than 20 centimeters per second. And again, those really low tissue Dopplers. And here we go, we can see very classical. And to me, this totally looks bright. I don't know how well it projects up on the big screen, but on my little screen here, it looks really echo bright, echo texture. So then we were going through the standard views, and this is something that we don't see a lot on transthoracic. But can anyone see what we're seeing in the left atrium? So I'm going to go back one. And if you want to focus in on the left atrium, and we actually have a really good view of the left atrial appendage. And what we found in this patient in sinus rhythm was a large thrombus in the left atrial appendage. So we were able to see that in transthoracic echo. So this is a feature of, this patient has pretty advanced cardiac amyloidosis. And this can be a feature of cardiac amyloidosis as thromboembolic events, even in sinus rhythm. And it's thought to be linked to an atrial myopathy, and we don't do atrial strain routinely, but when they did it in a study of well over 900 patients, and of those in sinus rhythm, 22% of them had really no atrial contraction. So amyloid gets in everywhere in the heart, within the myocardium, within the atria. As we mentioned, it can get into involve the valves as well. So we definitely see an atrial myopathy as well, and this kind of be very aware of patients with advanced disease, even in sinus rhythm, kind of thromboembolic risk. So again, we saw this apical sparing pattern. And again, this was much less marked because this patient much more advanced disease. So their overall global longitudinal strain was far more reduced than what we've just seen. Once it gets into the single digits, that's when I start to get concerned, and definitely less than -8. So once -7, -6, that's when I really think it's kind of very advanced disease. Another clue that we often see is, if you can see, this is the pulmonary regurgitation spectral envelope, and we've notching here, kind of indicative of poor RV compliance. So I frequently see this notching pattern in the pulmonary regurgitation spectral envelope. So I think that's another clue. So this patient, their genetic test revealed the V142I, as its kind of updated nomenclature is, the V122I mutation that we see in 3 to 4% of African American or anyone with Afro-Caribbean ancestry. So the classical features are severely increased LV wall thickness, the restrictive filling, the apical sparing. But what was also key in this was the reduced ejection fraction. People often say this is a disease of preserved ejection fraction, but as the disease advances, the EF reduces as well. So this patient had reduced ejection fraction, and hence kind of more advanced findings with the risk of thromboembolic events, even in sinus. Okay, so the next patient, again, this was an 85-year-old black lady who had had multiple heart failure hospitalizations. But what was interesting was her echo was measured as normal wall thickness. But if you see, there was one red mark on the septum where it was measured as 1. But when I remeasured it myself on the second red mark, I think I got close to 13 or 14. But her posterior wall actually was not that thickened. So kind of going against what I spoke about so much earlier, but that's kind of clinical medicine, isn't it? But you can see here on the apical four-chamber view, the entire septum is thickened. It's not just a degree of discrete upper septal thickening. Again, there's that kind of lack of longitudinal motion. Then her EA ratio, not that markedly abnormal, but her tissue Doppler indices are quite reduced, and she's a very elevated E over E prime, which was 38. And then What was also interesting was that the RV did look a bit increased in thickness. So this is a biventricular, like complete heart involvement, so we can also get RV wall thickening. And in her case, strain was performed. And the strain was done with Phillips, so you can see the slightly different appearance. And again, we got that apical sparing. So it was really in her case, because walls didn't kind of trigger too much, but when the strain was done, that kind of helped point in the right direction. And that lady also had, actually was sent for genetic testing with the assumption that her genetic test would come back positive because of her Afro-Caribbean ancestry, but actually she was wild type ATTR. And then the last case that I'm going to present to you is a patient who was referred for a TAVR. So we can see here, as well as having a thick heart, the aortic valve is very thickened, isn't really moving that well at all, consistent with aortic stenosis. We can also see there's a degree of mitral annular calcification. So when we look closer at that aortic valve in the short axis view, it doesn't really look like it's opening too well at all. And then when we calculate the aortic valve area and look at the gradients are not elevated. So we get a peak aortic valve gradient of 42, a mean aortic valve gradient of 26. So nowhere near the severe range. But when we calculate the valve area, we get a valve area of 0.7 centimeters, and indexed that was 0.33, so really in the severe range. So in these cases, we really use the dimensionless index to kind of help us, and the dimensionless index was 0.17, so markedly reduced. So all pointing towards low flow, low gradient, severe aortic stenosis. And that's kind of backed up by the fact that the LV stroke index was 23 mils per meter squared. So in these cases, we don't go anywhere near a debunamine stress echo. We kind of have our answer. The dimensionless index is so reduced, the valve area is so reduced. It totally makes sense that this is low flow, low gradient, severe aortic stenosis. And so then, again, what we talked about in these patients, the average S prime best predicted TTR in multivariable logistic regression of patients referred for TAVR. And earlier we talked about it being less than 6. Less than 5 is kind of easier to remember. And again, in this kind of patient population who was referred for TAVR, those with ATTR, who were found to have ATTR, which was close to 16% in this population, were 3 times more likely to have low flow, low gradient aortic stenosis. So it's really kind of a big hint. So in this patient, they went on to have a TAVR and are doing really well post-TAVR. So definitely the presence of of cardiac amyloidosis is not a contraindication for TAVR. So just things to remember was the LV fraction can be reduced in up to 50% of patients. I think a lot of it, like I said, a lot of the time we think it's preserved ejection fraction, but that just really kind of is at what disease stage we're imaging these patients. Women may not have the same degree of increase in LV wall thickness. And that's always key, like what kind of wall thickness did they start from? And again, as we keep on saying, don't attribute LVH to a history of hypertension. And strain imaging is incredibly helpful.